Hello and welcome to the presentation. My name is Stacy Parson. I am a licensed clinical mental health counselor as well as a licensed clinical addiction counselor here at ICGH Treatment Centers in Hickory, North Carolina. This presentation is entitled The Family System, an Integrated Approach to Care. As a collaboration within the community, with DSS, the jail, the court systems, the school systems, the hospitals, we all are in this together when it comes to helping our community be healthy and grow. So one of the things that we can do in collaboration together is assist with the trauma and healing of our clients. The first thing we want to try to identify is behavioral observations of what trauma looks like. So if we listen to our clients and hear their stories, we're able to link what we hear and see to empirical evidence, such as treatment plans and things of that nature. One of the things we want to watch out for is the re-traumatization of our clients and individuals that we serve. And the reason for this is that our body language, our facial expressions, and the tones of our voice can look to someone as judgment, and that is not going to allow us to help them in the best way that we can. Our approach to trauma is to let our clients know that we support them and we're here for them, and no matter what they've been through, we can help them get the care that they need in order to heal. Psychological trauma is definitely that emotional state of discomfort and stress, and that results from the memories and the experiences that has really altered their sense of self, their sense of harm and safety. And so gaining their trust is going to be difficult, and we need to do it very carefully. And so just being aware that the way we approach clients could mimic possibly an experience that they've had in the past. Behavioral trauma is sometimes conscious and sometimes it's not. They're actions that are associated with dealing with the stress that they have endured, and a lot of times, PTSD will allow somebody to be hypervigilant, shy away from you unwillingly or unknowingly, out of protection of themselves. And so we just need to be aware that the way they respond to us might not be us at all, but them responding to the trauma that they have endured in the past. So we're going to review a case study of an adolescent named Mitch. This particular child has expressed suicidal ideations. He's stating that he wants to hang himself. He has antisocial behavior. He's been throwing stones at the house. He's been climbing on the roofs. And during a recent episode at school, he substantially damaged the school building. Now, of course, there's going to be court proceedings regarding the damages of the school. Now, from the outside looking in, we might see that he is a bad child. He is, hanging out with the wrong crowd, or, not really caring about school. And his psychological assessment diagnosis would provide that he is emerging psychosis with with a mood congruent depressive content, suicidal ideations with paranoid tendency due to his idea of the world not being safe, and chronic unresolved grief with chronic PTSD symptoms. Now, when we label paranoid tendencies, that may be, in fact, based on evidence. However, he may seem to think that his world is unsafe because when he was 3, he saw his mother killed. And by age 11, he was present when his aunt was killed. So there's definitely some community violence underway. So to our knowledge, he probably didn't get any type of grief counseling or any support to help him overcome this trauma. Now, Mitch, if we're observing his behavior, his actions regarded are offensive to many and would attract a period of incarceration and community supervision. So basically, these children will probably go to juvenile delinquency or some type of program to help with their bad behavior. So, but the behavior suggests the likelihood that he's experienced distress and trauma, and he doesn't know how to deal with it. The court action, without consideration to his trauma, would see that he needs services that are not appropriate for his human rights, stating like, if we don't consider his trauma, then we're not giving him basic human rights to grow, to receive therapy to help him process this trauma, to build resiliency so that he can be in regular school systems without having to go straight into the criminal justice system. And this places the trauma with this kid as being a perpetrator and labeled as a bad kid instead of a harmed, hurt child who doesn't know any better. He doesn't have the supports, so we're giving him, an injustice service there. So what we want to consider is that the trauma is probably the single most important thing in this child's life and is going to be a challenge in order to help him break that level of insecurity and unsafety and get to a place where he feels secure enough to remember that trauma, process that trauma, and learn the coping skills and other skills that build resiliency so that he can flourish instead of being held down. The prevention that can minimize further complications would be physical health problems, intergenerational transference of those negative attitudes and behaviors, having addictions to drug and alcohol, being homeless, having their own children removed, the inability to identify or overcome sources of stress which life throws at us on life's terms without any kind of discrimination. So we want to display the attachment styles that play a major role in not only how we care for people, but how we as people attach ourselves to the world. So attachment is defined as the relationship between two people and forms the basis for a long-term relationship or bonds with other persons. So we attach to parents, to friends, to co-workers, even to our professional, like our doctors and such. So we are going to review a few of the attachment styles. So with identifying them, we can determine how we can identify trauma and how we can shift our clients from a trauma insecure style to a more secure style. Now please take note that much like the grief process, you can bounce around from one attachment style to the next depending on life's experiences. So with the secure attachment, there is a positive view of self and others, a sense of self-worth, and the confidence that others will be available and support us, and have comfort seeking and expecting comfort from others. So we just think life is great. People are for us, we're for people, and support is always going to be there. Insecure attachment styles are secure bonds that are not formed due to inconsistency, neglect, or maltreatment. And the child is highly prone to formulate a negative perception of themselves and other people negatively. So, delving more into the insecure attachment styles, there are a few of those. So we have the anxious, ambivalent style. And so in general, this encompasses the preoccupied and the fearful style of attachment. So when you have a preoccupied attachment, it is defined as a negative view of yourself, but you have a positive view of others. And it is being preoccupied with the attachment needs, and you are depending on others for personal validation, acceptance, and approval. Now, whenever you have an avoidant style of attachment, we have a positive view of ourselves, but we have a negative view of others. So it's characterized by removing ourselves from others, and we regard others as self-sufficient and invulnerable to abandonment by others. So we are thinking that we've got it under control. We do not need anybody. And the fearful style of the avoidant is defined as a negative view of self and a negative view of others. And so it's an uncaring and unavailable ideation of themselves. They don't feel lovable. Other people are not lovable. This is a really dark place to be. So whenever you have disorganized attachment styles, this is developed from experience in trauma or chaotic responses from your primary caregiver. So when children do not resolve or process the trauma that they experience at the hands of their caregiver, they may develop an inability to regulate their emotions when triggered, which kind of takes you back to the case study with Mitch. The emotional dysregulation may impede their ability to relate to others and create difficulty in their relationships with, new caregivers, teachers, authority figures, even friends. So the implication of the insecure attachments based off empirical studies have provided that evidence of insecure attachment styles increase the risk of psychopathology, depression, anxiety, and difficulties maintaining relationships throughout their life and having behavioral problems. Now, childhood trauma does violate the child's sense of safety. Evidence of trauma indicates a reduction of self-worth. It increases their levels of emotional distress, so regulation is hard for them. It increases their levels of shame and guilt. It incorporates destructive behaviors in the child's normal daily behaviors. Viewing caregivers as a source of inconsistency and fear and not a source of safety and nurture. So these children, adolescents, and even into adulthood carry these behaviors of not trusting in others and not feeling like resources are going to be consistent for them, so trust is going to be really hard to obtain. Destructive behaviors could be unchecked aggression, suicidal ideations and even attempts, substance misuse, sexual promiscuity, and even physical inactivity. So when we address children and their parents in the foster care, guardian ad litem, or even the kinship opportunities that are available, we have to address the children and the parents that are involved and how their experiences have created their relationships with one another. So children possess feelings such as lack of control and insecurity, which affect their ability to bond with caregivers. So by giving way to gaining control over their environment, the disorganized attachment style is usually going to be displayed. So you're going to have long-term outcomes associated with this style, including antisocial behavior, emotionally aloof, manipulative, and very little resiliency. When life happens on life's terms, they do not bounce back up. They kind of go down with the stress of whatever situation is being presented to them at the time. So the removal of children from their families of origin or wherever they are currently living could create an attachment injury, even though, pulling them out of the environment that they're currently in may be in their best interest. We still have to be cognizant of the attachment injury that can precede that move. So clinically here at ICGH, we want to be able to identify these injuries and the strained relationships that happen, whether this child is relocated from their school, so they're now a new kid in a new school, or they're relocated into a new family and they don't know anybody there. And so their behaviors and acting out might be due to the injury that created from that removal. So we have to be able to handle this in a way that's as least amount of damage to the child as possible, and enable them to learn these coping skills in helping them adjust to the new environments. So the factors that we want to look at that contribute to your mental health and the lack of social and emotional well-being is, grief and loss. We have depression, and we have traumatic stress. Now, we can have all of these simultaneously, and so we just need to be aware of who our client is and what experiences they have had to determine, is it truly a behavior issue? Is it truly depression? How can we help them with their anxiety and cope with their new living arrangements, new schools, new homes, whatever the case may be. So whenever you have at least 2 symptoms related to grief and loss, you're looking at an ongoing longing for that family member that they are no longer with, the grief or loss of their culture or community. So keep in mind that a lot of times whenever a child is removed from their primary caregiver and they are of any type of ethnicity and transported into a different ethnicity, we're breaking that culture of their community, and we need to be sensitive to that. And another symptom is emptiness, meaninglessness, and hopelessness, and then also bitterness and anger. So those contribute to your emotional well-being, and then as well as depression. So if they are displaying, body language or words that express being sad or unhappy, having a poor self-esteem, not thinking that they are good enough, or fitting in. And then, of course, we really want to be on alert for any type of suicidal ideations or attempts. And then the traumatic stress that goes here is that PTSD syndrome, symptoms that you notice with hypervigilance of easily being startled, avoidance of memories, avoidance of particular people or places, nightmares, intrusive thoughts, past experiences, and any type of numbing from these emotions. So these considered factors, we have risk factors, and then we want to look also at the resilient factors. So a risk factor is victimization, traumatic removal from their source, incomplete education or missed opportunities to learn, fractured identity, a sense of powerlessness, a lack of attachment, possible domestic violence, and other significant losses. So these risk factors, unless there is an intervention where there is coping skills implemented and learned and utilized, this can travel with them the course of their life and then to the next generation. The resilience factors that we want to build through therapy and collaboration with other entities is a sense of autonomy, the ability to know that you're in control of your own body and your thoughts, and you can do this, properly. Reassigning those memories of the past, those traumas, with positive memories. So retelling those stories with resiliency attached to them. Family ties, family tries to stay together. Siblings stay together. Family visits with positive memories. That's, sometimes whenever we have individuals who have open DSS cases and, they're learning resiliency and coping skills and a new way of living. And then those visits with their children can grow, and they can also experience, the children can also experience those positive memories as well, and the growth of a family in a new direction. Which moves on to developing new loving family memories, and the way we live, just the way we do our everyday life is different. This gives them a chance to have a mentor, have peer support, and learn to adopt responsibility. So in treatment, learning the tools is one thing, implementing them is another thing, but having that accountability and that support to say, yeah, you're doing it, and well, let's tweak it here, and yeah, you're doing it again, is very important in resiliency. And then just maintaining cultural knowledge and identity. So being cognizant of, what that looks like for each family system. So childhood trauma and adulthood. I know I've mentioned previously how trauma kind of goes from, childhood on into adolescence and then into adulthood. So whenever we're looking at a survivor of childhood trauma, they're more likely to have difficulty developing and maintaining relationships with caregivers and peers, and even, marital partners. So being more cognizant about what they have had happen in their past, we can actually help them in adulthood and shift that focus to create a different world for them now and also for their children. So we want to also tie in integrated services around not just peer supports, not just family, not just therapists, but also your physical health. So heart disease, cancer, diabetes, liver disease, these are going to be more prevalent in individuals who have had trauma and have not been able to heal from that trauma into adulthood. Also a link is between victim of a childhood trauma into adulthood is that they are more likely to be a direct or an indirect perpetrator or a high-level violence in adulthood. And this is due to that unresolved trauma and possibly undiagnosed PTSD, and they don't know how to deal with those intrusive thoughts, the nightmares, the hypervigilance, and it causes anger and just different ways of expressing themselves that is not conducive to a healthy member of society. So normalizing a family violence is identified through considerable evidence that the abused child is at risk for reenacting the original violent interaction. So that's where you have children who have been physically, emotionally, mentally abused by their parents, and then whenever they become parents, they also are physically, emotionally, and mentally abusive to their children. Sexual traumas also can fall into that realm as well. So that slides us into the intergenerational trauma. And this is when we're able to work with the entire family unit. We can work with the parents and help them to help their children, and then so on. So intergenerational trauma is the impact of a traumatic experience, not only one generation, but on subsequent generations after the event, also called transgenerational trauma. So the term transgenerational trauma is when the experiences of parents affect the development of their children and sometimes even their grandchildren. So it shows up biologically, socially, mentally, and or emotionally. So identifying the threats of intergenerational trauma within the parents and the children, we identify safety and felt security levels. So when you can identify those threats, you can identify what happens afterwards. So if we identify the safety and felt security levels, then we know when threatened, these individuals will have depression more than likely. If we analyze the attachments and the bonds when these people are threatened, then the results in loss and grief and damaged relationships. If we look at the justice piece, when this individual is threatened, it will result in anger and violence and often turn in on family, foster care, guardians ad litem, kinship, placement, and then identity and the roles. When those are threatened, it can result in isolation. And then the meaning and coherence of a person when it is threatened, this can result into alienation. So identifying the threats presented to children and or parents, adults, you can kind of see what would follow when threatened in a specific area. The impact of the threats can be identified here in this chart, where we have the identity of the threat on the left-hand side, and then we can determine if the threat, past, present, and future. You can look at the psychological responses, the adaptive responses, and the negative outcomes if the adaptive responses fail. For example, if an individual has an attachment concern, forced separation, losses, and disappearances have happened, your psychological response is typically grief and separation anxiety. And then when working with this particular person, we want to make sure parental protectiveness, attention to restoring the family and the networks are at focus here. But if that does not work, then we're going to probably end up dealing with complicated grief, pathological separation anxiety, and depression. So trauma and child protection. So trauma is experienced in any level of development, from infancy, childhood, adolescence, and adulthood. And what that is unresolved traumatic stress in a parent, which is a powerful contributor. So not only to parenting difficulties, but also regarding poor engagement with statutory agencies such as police departments, DSS, other things, school systems. So efforts of reunification are compromised unless the traumatic stress has been addressed. So trauma-focused CBT is a good option when working with the children and the adult in rebuilding those particular relationships. So evaluated levels of unresolved fear and shame are central to intergenerational transmission of neglect and abuse. So repeating the cycle of fear and shame from their infancy is reactivated by parenthood, leading to disrupted emotional communication. So based on the attachment theory, therapy work with adults helping identify parent-child relationships with their own lifespan highlighted their own experiences of seeking care and being cared for. So genograms place emphasis on their position as a child, helping to turn the parent's attention to their own childhood experiences, and it enables the parent and their therapist to identify individuals who played important caregiving roles in their childhood and in adolescence. So this exploration of memories, stories, and gut feelings about their childhood experiences assist in recognition of patterns. So they see the patterns in their own life, and then it can in turn help them see the patterns that they are creating in their current life with their children. So this identification of these patterns assists in the person reducing their shame, their guilt, their self-blame that can create difficulties in parenting, and provide a coherent narrative and create new meaning of their situations. So by doing so, we are developing empathy for themselves as a child, and they can strengthen their own identity while increasing their capacity to empathize with their own children. So when we are addressing and processing this model of therapy in collaboration with the community, what we're doing is we are going to be working off of evidence-based modalities. So some of the things that ICGH that we offer is cognitive behavioral therapy, and CBT has been empirically studied to address depression, anxiety, and substance use. So dialectical behavior therapy, DBT, has been proven to help treat mood disorders, suicidal ideations, and behavioral patterns such as self-harm and substance use. EMDR, which is eye movement desensitization and reprocessing therapy, is also used more so within the adult population and helps individuals relive, or not actually relive, but identify memories in their past, and not having to go into detail can be assisted by processing these memories with either tactile or audible or even eye movement to rewrite those stories, desensitize those emotions, and put a positive ideation on the experience they had as a child. And then also trauma-focused cognitive behavioral therapy. TFCBT is used typically for children from the ages of 3 to 18. And then, of course, we do offer in all of our services the 12 steps of recovery. This year, we are going to be part of a learning collaborative, and I myself am a participant selected for the NC Child Treatment Program. And this is for the trauma-focused CBT. And what this particular modality does is works with children who have had trauma. And the length of the treatment is roughly 8 to 25 weeks. Ages are, as mentioned before, 3 to 18. And will be provided with the non-offending caregiver. This non-offending caregiver can be a parent, it can be a foster care person, a guardian ad litem, kinship, even an aunt, uncle, whatever the case may be, as long as they are a person willing to engage in the treatment for a better outcome from the trauma for the child and the caregiver. So the outcomes of this modality is decreased symptoms of PTSD, decreased depression, sexual behavioral problems, disassociation, internalizing behaviors, and trauma-related parental distress, and improving parental skills. 61% of children in the U.S. are affected by violence, abuse, or crime, putting them at risk for things that happen in childhood and move on into adulthood if not addressed, which would be depression, academic problems, violent behaviors, substance use, delinquency, teen pregnancy, and other emotional challenges. So ICGH offers many different types of therapy. We have individual therapy for children, adolescents, and adults. We have family therapy. We have trauma-focused therapies, and we also offer gender-specific therapies if available. We have for our adults who have substance use or mental health diagnoses, we have medication-assisted treatment. We have community peer supports. We have prevention services. We have one-day recovery housing, which is linked to our services where they have the ability of sober living with substance use treatment. We link education, employment, and additional services within our collaborative connections within the community. We help with transportation at certain aspects. We have pregnancy support services, and we also offer higher levels of care for addiction, such as your intensive outpatient therapies. So ICGH staff, quality individuals who are licensed clinical mental health counselors. We have licensed clinical addiction specialists. We have certified alcohol and drug counselors. We have certified peer support specialists, prevention specialists, and we also have physicians and physician assistants that help us collaborate the care of our clients. So in order to get started with our services, we like to work with Department of Social Services, jails, other local entities, domestic violence shelters, homeless shelters, hospitals. We take referrals from almost anywhere, and we assess the individuals to help make sure that we can get a integrative approach of care to these clients, whether it is a combination of therapy and medication to therapy, housing, medication, there's an assortment of options available for them. So online intake forms are on our website. You can also fax in or visit a local office to fill out a paper copy of the the intake packet. So that concludes the presentation for today. And we'd like to thank you for being able to make yourselves available for this presentation, and just reach out to us for any type of questions or concerns. We would be happy to help.